No, then I would like to introduce our next speaker, my fellow colleague from Budapest and my former boss, Istvan Szikora, who is going to talk about the treatment of stroke in the public healthcare system in Hungary, how we set up our network.
Thank you very much. Good morning, everyone. Nuri, thank you for the invitation. It's great to be here. Never been here before, so thank you so much. I'm afraid giving a full picture of the stroke treatment in the public sector in Hungary would not be possible within 10 minutes. So I will focus on just one detail, which is using an AI-powered imaging network for that purpose in our country. So the purpose of this project was to presentation, to demonstrate the feasibility of building a centralized AI-powered acute stroke imaging network, and that is in a small to medium population density country or region, to provide fast access to imaging results for all involved parties, an immediate image analysis and reporting using artificial intelligence, and a communication platform between all players, including ambulance, emergency radiology, neurology, neurointerventions, in both the primary and in the thrombectomy centers. And this is in order to facilitate fast access to effective treatment of acute ischemic stroke for all of the inhabitants of the country or the particular region, regardless of the area of the residence of that patient within the country. Just a few words about the country itself. It's a medium-sized country of 93,000 quadrat kilometers with a population of a little bit less than 10 million and with a highly variable population density ranging from 52 to 200 in nearby Budapest and up to 3,200 inside the capital of Budapest. Hospital admissions for stroke are counted roughly around 30,000 in a year for the whole country. And this is being handled by 32 primary stroke centers. And on top, 7 thrombectomy-capable centers that are providing 24/7 service, and an additional 2 that is capable of doing thrombectomies 1 or 2 days per week. So the motivation of the project lies in, on one hand, the dynamic growth of thrombectomy numbers. You can see how the thrombectomy numbers has been growing from 2015, starting with 177 in the entire country, growing up to 1,200 in 2019. But unfortunately, what we also observed is that the mortality, the post-thrombectomy mortality, has also been growing during this time. So what you see here in blue is the 30-day mortality, and in the 90-day mortality, and in red is the 1-year mortality that has been growing from starting 20% for 90 days and up to 30% in 2019. So we were looking for the reasons, and we thought that one of the potential reasons could be the very uneven distribution of stroke centers. In red, you do see the thrombectomy centers, and in blue, the primary stroke centers. And that results that in the majority of the cases, the patients are transported to thrombectomy by drip and ship with a significant time loss in the primary hospital. We actually measured in our own experience a door-in, door-out time of 2.5 hours in 2019. This is before we introduced the system. So, and that, of course, will result in a high proportion of futile procedures. So we plan to provide a high-speed diagnostic tool as a decision supporting system to each primary and secondary centers throughout the country to facilitate a faster decision and reduce door-in, door-out time, and, of course, onset to treatment time. And also wanted to provide a communication platform, as mentioned before. However, that has been difficult to arrange for each individual hospital because of the lack of finances, and therefore we ended up using a European grant of the Human Resources Operating Program, which is actually aiming to reduce disparities in access to public services throughout the country, whatever public service is. So because in Hungary, healthcare is a public service, we could use this grant for that particular purpose. This is the system architecture. If a stroke CT is done in any of the primary stroke centers, let's say here, then the images in a DICOM format are being transmitted to a central teleradiology server, from where they are further transmitted to one of 4 different AI servers, where the processing is done. The processed images are sent back through the same way to the primary stroke center, but simultaneously also to the thrombectomy center, where the patient would be further transported if needed. At the same time, images are going to the cloud, and from the cloud became immediately available either on a desktop computer or on a mobile telephone. So I'm sure you all know how that system works. It provides an aspect reading, which is getting maybe less significant nowadays, having large strokes also capable of treatment. It is providing a large vessel occlusion detection, such as what you see here on an MCA main trunk occlusion. It provides a full reading and reporting of CT perfusion. And as mentioned before, the results are going to be available on the PEC system as well as on a mobile telephone or a desktop computer. Beyond imaging, it provides a communication platform as well. It is capable of collecting clinical data, such as, for instance, NIH-SS calculation. It actually gives you a recommended treatment option according to the valid guidelines, and it most importantly sends you automated messages. You can set up for what do you want to have an automated message. Either you can say that, okay, anytime a scan is being done with a stroke protocol, or if you have a large vessel occlusion, or a new patient is detected with a large. So you can set up all of this in different ways if you wish. We found that the correlation between the AI reading and the human reading was very good. So the correlation ratio for native scans was 0.999. If the patient had contrast before, then the accuracy of the reading is a little bit lower, and that's important to know because the system is not designed for that. Also regarding large vessel occlusion, we found the sensitivity to be at 0.86 and the specificity 0.9. The system performance is quite good. We introduced the system in the country we have 2 different systems which can work together. The larger one, including 28 hospitals, is run by us, and there is a smaller one for 10 hospitals in the southwest region of the country. So in our system of 28 centers, the total number of scans in the first 2 years processed by the system was close to 40,000. There was a very fast growth. Number of cases picked up very quickly and actually reached 1,500 cases per month in the first 6 months. Now the average number of scans per month is actually over 2,000. The majority of the cases are done together with CT angiography. We tend to believe that this is the number we are really interested in, because these are the patients who are likely to have a suspicion of large vessel occlusion to start with. We looked at the number of thrombectomies in the country. You do see that the number of thrombectomies has been growing from the very beginning pretty fast. There was a slowdown. These are the COVID years. This is the time when the e-stroke system was introduced. So now you see that there is again a fairly steep growth, which is 44% since the introduction of that network. Regarding the time metrics, we also, I mentioned before that the time of arrival to the thrombectomy capable institute was very long. We found that since the introduction of that system, this time, which has been almost 4 hours, has been reduced to 2 and 3/4 of an hour, which is still quite long, but that there is a clear reduction. lot of this is actually related to increased number of direct transport patients, but we still have quite a lot of drip and ship patients. And regarding the door in, door out time, we do see a 20-minute reduction, which is something, although by far not as much as what we would like to see. And these are cases from our data, which is a major hub doing more than 700 thrombectomy cases a year. So in conclusion, I would say that the application of a central AI-powered imaging system is feasible in this size of a country or a region. The system is professionally very highly reliable. There was no systemic downtime within these 2 years of working. It is used very actively. People are very happy using it. A number of scans are approaching the total reported number of strokes by now. There's a significant increase of mechanical thrombectomy numbers detected since the introduction of the system. A total time from first call to arrival to the mechanical thrombectomy center has been reduced by more than 1 hour, but further reduction of the door in, door out time in the primary hospitals is definitely needed. Thank you very much for your attention.
Wonderful presentation, impressive result. I don't catch the moment. The project was granted by the Ministry of Health, or?
Well, as we discussed with Sándor last evening, it's a bit more complicated. You mentioned something about a former socialist country, such as we are. So yes, it's a European. It was financed by a European Union grant. It was initiated by us. It was financed by a European Union grant. The European Union grants are handled by the government, with some section of the government. So this section of government was very well, of course, because I tell you, they checked every single letter or data protection, whatever you want, so it's a complicated issue. On the other hand, the health ministry, although this section of the government is part of the health ministry, but yet the top of the health ministry didn't really care too much, and just a few months ago, the minister said, "You have that system, really? I want to know about it. I never heard of." So, that's how it is.
Second, did it's possible to take the data from Hungary and to present to our Ministry of Health?
Oh, absolutely. That has happened before. I mean, in Slovakia right now, there is a similar system being built using Actually, I made a contact between the two governments. Same thing is happening right now in Slovenia. So it's absolutely possible.
The result for the only 2 years is impressive. Thank you.
Thank you.
Just one more quick question. It's a wonderful service you've built here. It really is impressive. Do you integrate your AI into all your communication tools as well?
What do you mean by that?
So in Scotland, for example, we've got a Pulsara communication tool, which integrates directly with Brainomics. So it's a one-stop shop for everything.
This is the next step which we are working on right now. Yeah. So hopefully it's coming.
Thank you.
I just need to find some other money for that.
Thank you. Any more questions from the floor? So yeah, I mean, this is really a game changer. So it has to be done because this is how you actually find your patients, and you make it a routine practice in the referral hospitals. So definitely, I think you should think about introducing it, and the communication platform will be the next step, and that's what we are trying to upgrade in the upcoming years.
Thank you very much.
Thank you.